All right, well, it's 8:30, so we'll just get the ball rolling here. On the last day of ISS, kudos to all that are still here. It's great. So you're here at the session. It's a course addressing equality for the aging, ensuring access to assistive technology for the aged care population. My name is Catherine Sweeney. I'm a physical therapist, assistive technology professional, and a seating and mobility specialist. I have been a PT for over 30 years, the last 15 of which I was a lead at a wheelchair seating clinic in Portland, Oregon. My current role is a regional clinical education manager for Permobile, and I am just kind of covering the Pacific Northwest all the way up to Alaska.
Thank you for coming today. I'm Heather Cianciolo. I'm an occupational therapist. Nice to see some familiar faces out in the crowd. I've been practicing for over 30 years. I started my career working in spinal cord injury, which is really where I ended up getting that bug to want to work and continue working with seating and mobility. I moved to Rhode Island, and that's where I raised my family. I still live. I worked at a rehab hospital for over 20 years in Providence, Rhode Island, where we started a wheelchair clinic that ran for over 20 years, servicing an outpatient, mostly adult population of all different diagnoses. I started with Permobile 2.5 years ago, and I'm one of the clinical educators. I cover the New England area and then upstate New York.
And then I want to introduce our third speaker today, who unfortunately kind of at the last minute couldn't join us because of a medical condition, but she is going to be participating. She's got such an integral role in the case study that we're going to go over that she's going to introduce herself, and then during her section, it's her recorded. So.
Hi, my name is Rika. I'm a clinical services specialist at Permobile, based in Sydney, Australia. I'm an OT by background, and I've predominantly worked in spinal cord injury across inpatient rehab, seating clinic, and spinal crash care clinic.
Okay, so I'm going to just, first of all, discuss a little bit how this idea came up as a group. Permobile, for those that are not familiar with Permobile, we're a global wheelchair manufacturing company for power and manual, and we have the benefit of having clinical educators across the globe, and oftentimes we'll collaborate on projects or other topics. And there was a discussion once about specific differences in how different regions of the world address the aged population, the aged care population, whether it be from a funding perspective and difference, or even just culturally, or how clinicians approach younger versus older populations. So we thought, the three of us actually were pretty passionate about this topic. So that's why we brought this forward, considering this is ISS. You guys are from all over the world. So that's kind of the origin of today. But I wanted to start by this quote from the World Health Organization, which is about assistive technology and what assistive technology does. So as a reminder, you're all here because I think you probably get it, but I would like to keep this as a drumbeat in the back of our minds when things get tough, either because of funding or because of some process got delayed. Sometimes I remember as a clinician, you get tired, but if we can kind of keep this in mind, and the World Health Organization says, assistive technology enables people to live healthy, productive, independent, and dignified lives, and to participate in education, the labor market, and civic life. Assistive technology reduces the need for formal health and support services, long-term care, and the work of caregivers. Without assistive technology, people are often excluded, isolated, and locked into poverty, thereby increasing the impact of disease and disability on a person, their family, and society. And I just thought, you know, nothing about that quote has anything to do with age. It doesn't talk about that's important just for a certain population of a person in the world or the age of a person. So when things get tough, hopefully that will continue to be the drumbeat. So jumping right in, the objectives for today, if we do our job, everyone will be able to list 2 challenges adversely impacting aging consumers who require wheeled mobility for functional independence. Also identify 3 wheelchair features or configuration concepts that could reduce the risks and costs of medical complications. And I'm passionate about that. We'll talk about that later because we all talk about least costly. We're paying for under prescription every day with complications that come up. So reduce the risk and costs of medical complications related to pressure or overuse injuries incurred by aging wheelchair dependent adults. Thirdly, describe 2 wheelchair features that may improve quality of life and functional independence for aging wheelchair users. And lastly, identify 3 best practice interventions applied to the aging population for procurement of assistive technology. And we know that the aging process takes a toll on our bodies in general. This is without specific disease considerations. We know that as folks age, we have changes in muscle mass, we have changes in the sensory system, we have changes in mobility, that's a given, we know that. And then we also have changes in financial resources depending on the person, you retire. So that left side of the slide is just the normal aging process. But the WHO also reminds us there is no typical older person. Some 80-year-olds have physical and mental capabilities similar to many younger folks, many 30-year-olds. Other people experience significant declines in capacity at much younger ages. A comprehensive public health response must address this wide range of older people and their older people's experiences and needs. They kicked off the UN Decade of Healthy Aging in 2020. So for the next 10 years, the UN has a focus on trying to decrease disparities between the aging population and the younger, not just assistive technology related, but along the healthcare spectrum. So the UN Decade of Healthy Aging seeks to reduce health inequities and improve the lives of older people by delivering person-centered integrated care.
Let's start off by reviewing
Rika.
current global data on aging. So when we first began researching this topic, global census and survey data told us that the world population is not only growing, but also living longer, which is honestly incredible. And it's generally a result of improved access to healthcare services and medical and technological advances. And while this longevity is generally considered a success, challenges are definitely arising for the aged care population. So we're seeing that this demographic typically requires increased functional assistance and healthcare costs that are related to significant comorbidities. When we dive into this a little bit further, we've got a case study to share with you guys, which really highlights that many of our government funding bodies are not keeping up in terms of policies and funding that would ensure our aged care population is able to access necessary equipment and care to increase their functional independence and keep them living within their own homes as long as possible. On a positive note, population aging really is a human success story and gives us a reason to celebrate the advances of public health, medical advancements, and economic and social development over diseases, injuries, and early deaths that have reduced the human lifespan throughout history. However, with the number of older people projected to double over the next 30 years to 1.5 billion in 2050, what impact is this going to have on equitable access to assistive technology for those with mobility impairments? Coming from the land down under, there are quite a few things we're well known for, although our aging population and prevalence of disability probably isn't one of them. When looking at data from the Australian Bureau of Statistics, it's clear that the prevalence of disability increases with age. We can see here that almost half of Australians aged over 65 have a disability, accounting for almost half of all people with a disability in the country. When reviewing specific data on spinal cord injury, we can also see that the mean age of people acquiring SCIs is rising. We'll be looking into the different impacts this has on access to equipment and care, as our eligibility to different funding bodies is age dependent. When looking at the US, we can see that the number of people aged over 65 is predicted to increase to 20.6% by 2030, which has almost doubled since the year 2000. Similarly to Australia, we can also see that the prevalence of disability increases with age, with the top graph highlighting ambulatory difficulty. We can see here that 15.4% of those aged 65 to 74 experience difficult walking or climbing stairs, which sadly increases to 48.4% in those aged 85 and older. And again, no real surprise here to see that England and Wales are also experiencing a rise in their ageing population. The Office for National Statistics highlights that the proportion of people who reported disability increases with age, with 42% of people aged 66 years and older reporting a disability. The World Health Organization has declared that 2020 to 2030 be the decade of healthy aging, with the goal being to optimize older people's functional ability that enables well-being into older age. The Decade of Healthy Aging baseline report emphasizes that optimizing functional ability is key to healthy aging, along with the need of governments and other stakeholders investing in data to monitor healthy aging across the life course. The report recognises that although some decline in capacities may be unavoidable, older people at any age should have the ability to meet all of their basic needs, and approaches should mitigate inequalities and opportunities. The Decade of Healthy Aging will focus on the following 4 key actions. 1, changing how we think, feel, and act towards age and aging. 2, developing communities in ways that foster the abilities of older people. 3, delivering integrated care and primary health services that are responsive to the needs of older people. And 4, providing older people with access to long-term care facilities. To introduce you to Chris and Bobby English. So Chris was actually a patient of mine who I worked very closely with for about a 6-month period during his inpatient stay at the spinal unit at Prince of Wales Hospital in Sydney. Prior to acquiring a spinal cord injury, Chris was a very healthy, independent 69-year-old man who lived with his wife, Bobby, in their self-owned home, where they'd actually resided for 26 years. So him and Bobby had been married for a number of years. They had 3 adult children and 3 grandchildren. Chris was a really proud, active community man and was the president of his local Lions Club. He donated plasma once a fortnight, so it had actually saved multiple lives. And he still worked full-time as a jewelry maker, where he owned and ran a small business. He was independent in all aspects of his life. He didn't have any impairments with his mobility, and he still drove. Unfortunately, on Chris's 69th birthday, he acquired a C3 ACC spinal cord injury after falling downstairs at home. And although Chris had partial innervation in all 4 limbs, this movement wasn't consistent, and he often experienced really significant spasms. So Chris relied on a chin-controlled joystick to operate his power wheelchair, which he was dependent on for all of his mobility. He also required 24-hour care a day and needed assistance for showering, dressing, toilet, eating, and transferring. In the space of a few minutes, Chris went from being independent in all aspects of his life to having high-level care needs and being dependent on someone for all of his ADLs. Chris's high-level spinal cord injury, he required high-cost equipment to increase his functional independence and also to facilitate his discharge home. One of the first things we'd need to do as therapists working in the hospital was determine which funding body someone would be eligible for, which in New South Wales, which is a state in Australia, is age dependent. I'll start off with a disclaimer that definitely appreciates that Australia has one of the best public funding systems in the world. However, the discrepancies between funding bodies is huge, and as I mentioned, is actually just age dependent. So we have the National Disability Insurance Scheme, the NDIS, which funds supports that helps an individual reach their goals and increase their functional independence and participation. Unfortunately, the scheme is only available to people with a permanent disability who are under 66 years of age, and therefore Chris wasn't eligible for NDIS. Chris was eligible for Enable New South Wales, which is a statewide government-funded equipment provider who provide equipment on a permanent loan basis to people with chronic health conditions or disabilities to assist them with mobility, communication, and self-care. Often when we look at wheelchairs in particular, upcharge features, which will be funded through NDIS, are generally not covered by Enable New South Wales, so the selection of equipment is quite limited. Chris was also reliant on a My Aged Care package to fund his care. It's probably worth mentioning that once someone becomes eligible for My Aged Care, they're no longer eligible for Enable New South Wales, so any further equipment that's required must come from the package they're assigned. My Aged Care packages generally have about a year-long wait list before someone actually gets approved a package. Chris was pretty lucky though, and within the hospital system that did get escalated, so he was approved a level 4 My Aged Care package, which we were quite sneaky in terms of when we do the application to make sure he'd already been approved his equipment through Enable New South Wales. Because as you can see here, the level 4 care package wouldn't have been enough money to fund his wheelchair, commode, bed, hoist, and other types of equipment, as well as leaving him enough money to actually be discharged home. So let's have a look into how the funding body actually impacted Chris and Bobby on a daily basis. So as I mentioned, Chris was approved a level 4 My Aged Care package, which equated to $53,200 per year. However, once admin fees are charged, Chris was only left with about $36,000 a year, which equates to about $24,000 US. Given Chris required 24-hour care, this amount of funding equated to 1.5 hours of formal care 5 days a week, with no money left over for any additional equipment needs. So this really meant that Bobby became Chris's full-time carer, along with their daughter who assisted Bobby with completing Chris's bowel care and showers daily. It was really lucky that Chris's initial equipment was funded through Enable New South Wales, and he was discharged home with a power wheelchair, new chin control swing away room, a floor hoist, a commode, a single high-low bed, and an alternating air mattress.
So now I think I'm going to step in and I think part of what Rika and Catherine have really highlighted is obviously the data and statistics behind why this aging population really requires this additional look from us as clinicians. And as we move into this next section of the presentation, we're really going to take a better look at how we can then implement this and bring this back to our practice. So let's take a look at some of those actual access barriers that are facing the population. And here we can see the World Health Organization, the global report that came out in 2020, and they really identified many different misconceptions and barriers to assistive technology for the aging population. And they did implore that it's very important to keep that strategy of that, again, person-centered approach in order to engage those users and match that appropriate equipment that they need. I think it's also very important that we look at some of the statistics. And when we look globally, what I found really interesting in this report was about 3/4 of the countries don't report on any aging, whether it be healthy aging or aging with a disability. So from that standpoint, that population now becomes even more invisible if we don't have some of that data being reported across the globe for us to better interact and make those changes. So knowing this, how do we do this and implement this in our our daily lives and practices? So we're going to now look beyond those barriers and let's explore how that CRT mobility solution can decrease that risk for medical costs and complications, as well as improve that quality of life and their functional independence. So we can look to the literature that can tell us, again, that a person-centered CRT mobility solution for that aging population can really continue that independence and quality of life. The research supports that optimally configured manual wheelchair with all its parts and setup really do improve that functional performance and outcome. So the question to all of you is, well, why wouldn't we continue that with our aging population? If we know and we consider that for our younger population, why wouldn't that just be the standard of care for anyone? And then despite whether it's someone with a chronological age, again, of 20 or 85, it really shouldn't make a difference in how we're looking at that assessment and matching that piece of equipment. I think it's interesting when we were putting this presentation together, I decided to take a look and what are we being bombarded with, right? We have a ton of social media. We're all on our internet and Googling, all the different sort of key phrases. And I sort of typed in geriatrics, older population, wheelchairs. And what popped up were the images of that dependent person like we see in the picture on the right, that's in that either transport chair or maybe in that sort of rental grade, that lower end manual wheelchair. And sure, all the pictures, they look happy, but look at how dependent they are, not only for that positioning, but dependent on then a caregiver. So that lack of independence is really been promoted by that type of equipment that they're being provided. But interesting to see that in our society, that 95% of those pictures I pulled up with just that quick search engine really was showing that dependent person that was aging. And I want to say and challenge to all of you, well, let's look beyond that. And, what does it look like? What does someone look like who's aging, who can maintain that independence and foster that function? And I think we look again to that picture on the right, which all of us in the CRT industry, I think, can appreciate. And that's what we want to see. We want to see more of that. And again, the bias that's behind some of our maybe social media and some of our postings and some of our websites that, again, are looking that don't promote that picture of independence with that older person. So here we can see some codes that are very typical to the US with the Medicare, what we call the HCPCS codes. And they really represent those medical procedures, the supplies, products, and services. And I think most of us are probably pretty familiar with these. Just sort of pulling out that sort of what we consider that K1 through K3 is really that basic piece of equipment, really meant for more that person that's going to have a temporary disability or has had an acute issue of maybe a surgery and requires that sort of just that chair to get home. But it isn't meant to be that long-term piece of equipment. But how many times have we seen discharges maybe from a rehab hospital to maybe a home placement or maybe a different placement where that's what they're being given and it's never reassessed. And maybe that, again, their independence level doesn't change. And then all of a sudden, now this person's been 1, 2 years, 3 years in that chair that was really meant as a basic get home and hopefully get better chair. But they haven't. So now the implications of putting and keeping someone who now is disabled and again, looking at this as well as aging, is really then put a disservice in the sense of what they can do for themselves and the capabilities of these chairs. So really, when we then start to look at, well, how can we better their situation? It doesn't mean that the K1 through K3 isn't maybe appropriate in some situations, but when we're looking at that aging person who's now aging and with a disability, how can we better their situation? And shouldn't they be given that right to be assessed, to be given that opportunity to improve their function? So we come up with the sort of a K4 level, which is that high strength, lightweight. It is lighter. It does have a few more options and adjustability. However, it really is still, again, a more standard chair. We have limitations in what we can adjust to accommodate for that aging person. And as Catherine had highlighted, we do know that there's going to be changes in those body systems. So being able to have a chair that can accommodate maybe those changes currently as well as they continue is going to be really important. That K4 is not going to have that ability to change with that client. And so that moves us to focus on that K5 ultra lightweight, high strength category, which all of us know sort of enters into that CRT bubble, I'll say. But really that defining characteristic of these K5s is going to be that adjustable axle. And that's going to make a huge difference now for our clients that need that adjustability and that ability to bring that rear wheel to not only a vertical position, but now a horizontal change of position, So moving it up and down as well as forward and back to really dial in and optimally configure that chair for that center of gravity. So now by moving that mass and allowing that person to have better access to that wheel, we're now promoting that propulsion technique in the mechanics. And as we know, we bring this back to that older population when we're seeing those changes in range of motion, in strength, in endurance, that ability to change that center of gravity, and as well as all the parts and configuration of that chair, we're now setting them up for a more optimal situation for success. Which moves us, if we take a little closer look at that center of gravity. I really love this picture here because it really highlights with that sort of red line down the back where those more standard basic manual wheelchairs come into play, and where that center of gravity can't be adjusted more anteriorly or more forward. And how, if we look in and compare it to where that body is in space sitting in that chair, the significant difference that makes then for where their arms need to be, where that weight is being distributed. So then again, that's calling for how can we adjust that to then improve those biomechanics? And what we know with the evidence that's out there, that that's going to improve the efficiency and function and hopefully long-term use, keeping them in that maybe manual wheelchair and independent with function. And I think as we look, someone may say, well, what really changes when we move that center of gravity, or we can see with that blue dotted line more to the center of the patient, of the person, and coming down sort of through the head, shoulder, and pelvis to center that weight more appropriately in the chair. And we can look to the sort of this diagram here, which I think really helps us to understand that impact if we don't move that center of gravity and what this person may lose. We can look at that increased wheelchair footprint. So by not moving that rear wheel forward, we're now increasing the turning radius and how much space that person has to maneuver in their home possibly. And if we think about some of our older clients, we think of sort of the supported living environments that many of them have to move into, and the amount of time and space and sort of limited ability to maneuver many times in maybe a bathroom, a hallway, a bedroom. So not having that adjustment can make a huge difference for functionality in those spaces. If we look at some of the others, such as the increased rolling assistance and resistance that's needed with that rear wheel isn't brought more forward. If we're looking at that decreased range of motion, that may be restrictions in the strength, that by not bringing that wheel forward, we're really, for that aging client, reducing their access to that wheel and then limiting their ability to be independent. And yet often I think, there's that perception that older people don't need a sports chair. I mean, how many times have you been in the clinic and you've had maybe a client and they've been there with their son or daughter, and then you've brought out maybe, again, this K5, this ultra lightweight, high strength, configurable manual wheelchair, and the family member looks at it and says, oh, well, they don't need that. That's just a sport chair. So again, what our society and some of our biases as to, who can use a chair that's highly configurable, and it's not just a sport chair, right? This is about everyday life, and that we need that configurability and that adjustment in order to make it functional for every day. So I think it's so important to sort of move past that, but many times it really takes that extra education and really sort of showing, and I think that's why that trial process, when we look at sort of that prescription process, is so important, because many times it's really getting someone in a chair and be able to have them feel the difference between what it means to be in that K1 through K4 versus that K5, that ultra lightweight. And sometimes, when you look at it, it's going to be a lot different than when you're in it. So really getting those clients in it during that education can make a big difference. And acceptance for many times for maybe that caregiver that's showing that bias towards their maybe older family member, that they're supporting, but they're saying, well, why do they really need this? And this is a way to really be able to demonstrate those benefits. Especially when they can see by moving that maybe rear wheel forward, the access to that wheel. And now all of a sudden, that individual who maybe is at home and, the family member is complaining, well, they're only going 10 feet. They're only going from the bedroom to the bathroom. Why does this really make a big difference? And then all of a sudden, the person saying, well, oh, this is so much easier. And all of a sudden they don't need to be pushed. And now they have that energy to not only do that propulsion throughout the day, but now they have that strength and maybe endurance to maybe continue to feed themselves, to do those other transfers that needed more assistance because they were so fatigued from trying to push that ill-configured manual wheelchair. So really how that can make a huge difference for both that individual aging as well as maybe their caregivers. When we look at this picture here, I think what stands out to me is really some of the very typical changes that we see in the body as we age, one of which being that spinal process. And looking at that alignment, it's one thing when you're standing, and of course I look at this picture and want to stand up nice and tall. But now consider you're sitting all day and you've had these spinal changes. So that alignment is going to be really very significant with that sitting posture. And how does that translate, and why is that important then that we look at some of these sort of expected or very common body changes, and why then that ultra lightweight, highly configured manual wheelchair is so important? And here we can see our nice little person with that kyphotic posture, sitting in that sort of what I consider a more standard sort of basic chair. And as they're sitting here with that kyphotic rounded posture, the posterior pelvic tilt, if they were in a standard or basic chair, we wouldn't be able to accommodate for any of that curvature or changes. And so are we then pushing them towards more with gravity, we know is always acting on our bodies, towards more asymmetries and more dysfunction? How is this going to affect if we can't change that position of maybe the recline angle to accommodate for that kyphotic posture that may not be flexible? How is that going to affect their respiratory? How is that going to affect the positioning and use of their upper extremities? Maybe it's going to affect their balance. And we know that there's a high risk of falls with the aging population. So all of this really comes into play, and it's why we need to consider then that wheelchair then can make those changes and accommodate for the aging process. The other one is taking a look at, we see that upper and lower extremity weakness and that decreased range of motion. So being able to, again, accommodate maybe a seat depth change, so that maybe now they have the ability to do, or a seat to floor height, that foot propulsion, because they now have had maybe a CVA and other diagnoses on top of just the aging process. So now we need to get them configured and set up in an optimal configuration that can only be done with that CRT piece of equipment to optimize their function. And then we can also look at a very common one, shortening of the hamstrings. How many of us have been in the clinic and this? I used to cringe. I used to have two scenarios that would come in the door. One was when someone came in on a stretcher, because then I was like, oh boy, we don't have any equipment and where are we going with this? And then second one was when that elderly patient came in and all of a sudden they're in that standard or transport chair, they have elevating leg rests on, and all of a sudden the legs are elevated, they're tilted back, the caregiver's complaining, they're constantly sliding out of the chair. And you're saying, okay, we have a lot to work on here. Not only are we doing the assessment of, the body and structure, but now we're also trying to educate that individual who's helping, or maybe a caregiver, as to why they need this new chair and all the parts. I think of all, particularly elevating leg rests. That tends to be one of my pet peeves. And all of a sudden, here we're looking at that very common, the shortening of the hamstring, and all of a sudden, they're sliding forward because they're trying to get their feet on the floor. And the first thing we see in maybe some of the facilities or even at home with caregivers is they put elevating leg rests on, they crank them way up, right? And as we know with the hamstring, which passes over two joints, that's just making that situation more complex and more complicated, and really leading to possibly other changes such as maybe skin integrity and postural inefficiencies. So really taking a look and knowing that we're going to see some of these body changes and how that K5 or that ultra lightweight, that highly configurable chair can make that difference with some of these expected changes. The other thing that I think I hear all the time, and I would hear in the clinic, was, well, we just need a chair that's lightweight. But as we look at the current research that's out there, it's more than just about the weight of the chair. Yes, that's definitely a consideration. But when we're looking at that highly configurable, high-end manual wheelchair, that CRT piece of equipment, we need to look beyond that. And it's more than just again, that frame. It's about the wheels you choose. It's about the casters. It's about, again, the arms, the leg rests, and all of that really can have an accumulative effect on the efficiency as well as the rolling resistance. And if, with this population, so many times, depending on where they're living, many times they're doing sort of short bouts of propulsion, right? So they're maybe only going 5 or 10 feet. So that means a lot of start and stops. And when we look at the research, it's really that increased exertion when we're doing that push phase that requires all that extra effort. So if we're putting all these extra parts on this chair, for one, we maybe now that lightweight frame is no longer light, but also are we adding then increased resistance for them to initiate that mobility? So even as if we pull out a few of these sort of excerpts from 3 of these, at least 2020 research articles, we can see that configuration and fit are more significant than the weight to decrease rolling resistance. We can see that this is, I think, always interesting to a lot of people, but an underinflated pneumatic tire can have less rolling resistance than an airless insert. Which again, how many times do we see, and we're prescribing a manual wheelchair for someone who's going home, and the caregiver is like, yes, we want lightweight, but we also want it really durable. We don't want to have a lot of maintenance. So what's the first thing we put on is that, mag wheel, right, with the airless insert. But how much weight, and when we look at it, the inertia that it takes to overcome and initiate that movement is much greater. So it's always a give and take, right? What we choose on a chair and those parts and the configuration, it's always that give and take. But if we're looking at improving that function for that aging person, then we should look at beyond just the frame. And maybe it is then explaining why that air tire with spoke wheels is going to make that difference and decrease that exertion level and maintain that independence. I love this video here, which I'm going to play for you. And it's showing the tire on the left and wheel is actually a mag wheel with an airless insert. And the wheel on the right is actually an air tire with spokes. And as you can see, which one rolls much easier? The one on the right, right? The tire with air and the spokes. So if we're putting all of our aging clients in that now highly configurable chair, and we're putting on that mag wheel with an airless insert, is that something that's really going to hinder versus help them? I don't know. And maybe, again, there's those reasons for choosing that. But knowing that these are the parts that you pick, even the caster size, the width of the caster is going to make a huge difference for that what we call that scrub, or again, the amount of resistance when you're making turns. So think about now that older person who has diminished range of motion, diminished strength, diminished endurance. And now, yes, we put them in a lightweight chair, but now we've put all these components that are actually making it harder to initiate that movement, and not only to move forward, but to make those turns. So improving a user's propulsion as well as postural stability really leads to a position of function. And we can see here a study with Rika in 2015 is really showing that optimizing that configuration is really promoting function and change. So putting someone who's older in that highly configured chair, are we setting them up then to be able to do other aspects of their daily life and have a better quality of life if we can and promote that, again, highly configured chair? So I think these two videos that I'm going to play for you really help to demonstrate why it's so important to customize that chair to the individual and how they're going to use it and in what environment. This is an older gentleman. He's actually a little on the heavier side, which I think we do see in some of our older population. We do see an increase in weight gain many times with that decreased mobility. So having a chair that's fit not only for their size and dimensions, but also how they're going to use that chair is so important. So if we look at this first video of this gentleman in the, let's see if I can play it. If it wants to play. Here, he's using his lower extremities to propel. You don't see him sliding out. You see his posture very stable, but he's very independent in using that foot propulsion because of the way that chair has been configured. And it really is then optimizing how he can maneuver in that sort of small hallway area in his home efficiently and effectively. Whoops, go back. And we can see here from this picture, this CAD drawing on the left-hand side. I think it's important that sometimes we have to think as clinicians or even suppliers and go beyond what's really just sort of out there, what we see just as sort of a standard in the wheelchair design. And maybe it's looking beyond doing something more custom. So this is a perfect example with this gentleman that we just saw coming through the hall with foot propulsion, with a customized front end on a rigid chair. So he's getting the benefits of that rigid chair, but the ability to propel using both lower extremities without hitting the front leggings, anything that's in that sort of front area that would impede his mobility. And here we're watching now by promoting, again, that optimal custom configuration. I'm having trouble getting that to play. Is just a nice transfer. Which is not, why am I not? Oh, here we are.
So this gentleman, his most effective propulsion technique was foot propulsion, and he was struggling to reach down for the foot plates. He was also able to get closer without having to manage the swing away of a regular. So as Heather said, you could really center his weight properly over that or that rear wheel underneath him, and then he could transfer independently without having to mess around with leg rests that might come off. But he did not, for his upper extremity limitations with arthritis, he couldn't effectively, or that repetitive motion was going to be a problem.
Yeah.
Yep.
So just a good example of sort of thinking out of the box and maybe doing something that's more custom to maximize that functional performance. And I think for some older adults, many transition to some type of supportive living environment. And many times, that there may be restrictions. Maybe it's someone moving to assisted living or a nursing home placement, or maybe it's the restrictions given by a caregiver. And now they're showing signs where they can't be independent with traditional propulsion techniques, whether they're using upper or lower extremities, despite the well-configured manual wheelchair and parts. And so now you're, as a clinician, you're thinking, well, what are my options? Am I moving right to sort of that power mobility base? And how is that going to work in there where there are constraints of maybe that environment? And sometimes we can look to the power assist option as a way to sort of bridge that gap and maybe allow someone to gain that independence or remain independent with some type of propulsion without that increased effort. Without having to go to the full power wheelchair. And I think this is a nice way of being able to, again, bridge function for maybe someone's older, who may not, maybe even in that assisted living or that nursing home, that they may say, well, we don't allow power here. But this may be a way to prove their independence and keep them mobile despite being in a more dependent situation. And maybe they need, such as this person that we see here on the left, He's actually 85 years old. He's a Canadian gentleman. And he was in actually a nursing home placement and needed that tilt and space manual wheelchair for some of his positioning needs and skin integrity, as he has multiple comorbidities, and you can see he has a CVA. But by giving him that power assist, even in a tilt and space manual wheelchair, we now provided that independence and that ability to maintain his ability to initiate movement. Interesting sort of fact here for him is that during COVID, when there was staffing shortages, it was actually the ability to use his power assist to get to his dining room and his activities when they were short-staffed, that gave him that ability to continue that those life roles, even in that nursing home placement. And then just one more video here is we're looking at Alvin. I'm not good playing this. Alvin, who's actually using power assist, he's a veteran. He's 90 years old. He was living with his son. 96 with his son. And pretty amazing to, again, get those benefits of maybe maintaining his posture, his transportability, his maneuverability in the manual wheelchair, but gain and maintain his independence to initiate his movement throughout the home and community.
He was dependent
Prior.
before this, so it may not have been tried because of his age, and then he became distant supervision of his family.
So pretty amazing that, again, thinking beyond, he wasn't appropriate for maybe or use or function of a power wheelchair because of his environment, but this gave him that ability to maintain that independence or gain that independence that he didn't otherwise.
I want to add one more thing about power assist. When it first came out as a technology, it was really for considered at least either the hub mounted, and that was for, you know, folks that needed it all the time, or the removable ones were like, oh, only for folks that go far and fast. But really, if you think about how many of our clients at home have carpet that we've moved to a power chair because of carpet, or fatigue at the end of the day, their day ends at 2. So it's really, now we're evolving our perspective on power assist, that why move into a power chair if they can't transport it to begin with? If they're struggling with manual, it doesn't mean everybody needs a power assist, but you know, we might need to really push hard for insurance to consider it, because it can be more expensive. It is more expensive than a basic power chair, but it may not be the most, it may be the most appropriate for that person. So explaining that impact on in-home use in their environment would really help.
Yeah.
Yep. Great. A few more minutes here.
Yes, great. So just going into, as we look and we go beyond then maybe that manual wheelchair and even the power assist, we look at sort of power wheelchair considerations and how power wheelchair components, not only the base, but also the programming and some of the seating functions can really make the difference, justifying the success and the appropriateness of CRT for the older user. If we pull out a few, looking at maybe just the size of the font and the screen, being able to make those adjustments for tremor dampening or for increased weakness and fine motor control. Taking a look at, again, memory seating. So now someone who maybe has some cognitive changes has the ability to utilize those power seating functions, maybe for proper skin integrity, balance, sitting posture, but can have a shortcut to be able to easily gain access and use that functionally. Also looking at some of those seating and positioning considerations, it can make the difference by using that anterior tilt to maybe gain that access to be independent with their ADLs. And here's a picture of Anne here using her anterior tilt with a front wheel drive base, which otherwise she could not have access to her sink to complete her hygiene independently without the use of that power seating function, as well as that base configuration that allowed her the maneuverability within that environment. And otherwise, I think we were talking about this earlier, she had a basin that was on her lap and had to be dependent on caregivers to help her with her hygiene.
Like a hospital, what you get at the hospital. That's where she'd been doing for years, her self-care for getting her teeth brushed because she couldn't get over the sink.
So important how that the combination shouldn't be overlooked. And this population, just because maybe the training or considerations for safety may take more time or need more consideration for how you're presenting that, shouldn't be overlooked. And just another good example, as we talked earlier, falls are a great risk, especially for the aging population. And it may be the use of a power seat function, such as this individual here, who's 90 years old with ALS, living with an elderly wife, but using that anterior tilt is bringing him to a position that now what he was dependent with transfers prior, he's now just a standby like contact guard, but can basically do all the physical ability to shift forward and then do that stand pivot transfer to the other surfaces without that risk of fall or decreasing that risk of fall for both him and now his elderly caregiver. So I think it's a great example of using those power seat functions to enable someone to stay in their home environment and promote that independence. Historically, we can look to the research that provides that insight and guidance into that application of power seat functions and how it can promote those medical and functional outcomes. I think it's important here, as we can see from even that Rahev study in 2015, looking at spinal cord injury, is that significant change in skin integrity and how they're at much higher risk of skin breakdown and pressure injuries. So why wouldn't we want to then consider knowing some of this data and this evidence to put in best practice and then look and assess the need for not only power mobility, but seating functions and programmability.
I was going to add one more thing here. I found in the territory I cover a real disparity between how clinicians in the US consider power seat functions based on age. I've had several clinicians say, well, it's too complicated to add tilt and recline and legs. They just can't do it. And it can be complicated for anybody, but I think there's a lot of great features and we can use our ATPs to help with this. There's ways to make the chair simpler. So you could offer all three functions and run it with one touch of one button. And the chair will move in the right, sequence for getting their pressure relief and sitting them back up without them sliding out. So I think we just need to keep challenging and keeping up to date and advocate for enabling the seat functions or enabling the technology to make it easier for the older population. And this is a good example because I've had clinicians say, nope, let's just do tilt. And it's not as effective. And this is aging skin.
Yeah. Great. So now just circling back to our case example that Rita has provided us. And just again, re-emphasizing that this gentleman, Chris, was able to get equipment. However, looking at how his care continued when he did get home, that burden that was actually put upon his family because not all of his care could be provided because that was based on his age and with the funding.
One last little bit from Rika here.
Right at the beginning of sharing Chris's story, it probably sounded like he was blessed with funding. There are actually a number of items that would have increased Chris's quality of life, independence, and reduced his care needs. These are some quotes from Bobby. Chris couldn't get involved. He couldn't project his voice. On days of Chris's suprapubic catheter change, he would have to be in bed until a nurse arrived. These occurred once a month. Chris was donated a standing frame, which he loved, but we needed 3 people to get him in it, so could only manage this once a week. We had to make sure there was always enough money left over just in case I got sick. Who would care for Chris if I couldn't? In the end, Chris stopped wanting to go out. He was self-conscious about his power chair. If you look at the ideal world situation, Chris would have been eligible for NDIS if we had those pesky age brackets removed. Funding through the NDIS would have meant that his equipment just needed to represent value for money and increase functional independence and help him pursue his goals. For someone with the same level of spinal cord injury as Chris, we would generally see about a $500,000 package being approved. In terms of the mobility equipment, this would have enabled Chris to have access to. We could have scripted in additional power seat functions that really could have helped Chris increase his independence. So Seat Elevate hopefully would have helped things like communication. It would have also been a real help for Bobby, who had to bend over to assist Chris with feeding daily. Power recline and elevating leg rest would have meant that Chris could have had the suprapubic catheter change done in his chair and wouldn't have had to be in bed until a community nurse turned up to change the catheter for him. If we scripted in standing as well, that would have meant that he didn't need 3 carers to come to his house to help manually get him into that standing frame. A ceiling hoist as well would have decreased his carer needs and really decreased the manual handling involved in transferring Chris from his bed to commode and power chair. It also would have meant that Chris would have had access to ongoing therapy. In terms of his care, which was really one of the biggest things for Bobby, it would have meant that he would have been approved 24-hour care a day, and his family wouldn't have had to provide any other additional supports.
Okay, we're just going to briefly cover what, little best practice topics here. In terms of the ICF, we probably are all familiar with the ICF, but I want to call attention to the outer circle. So the ICF, where we live as clinicians, is that center section. So we're assessing the client, we're looking at participation, and we're looking at their life needs. And then we're trying to pick the right equipment to meet the deficits and improve their participation. This is an evolving model that was started in 2000 by the World Health Organization, but that outer circle was added in 2010 as a suggestion of how we need to not only deal with deficits, but improve quality of life. So it goes back to, are we listening to the client's goals? Are we listening to what they want to maintain and achieve in order to improve their quality of life, which reduces equipment abandonment? So I really love this model that included that. Worldwide, we're going to have a different team and what we call those team members, but here's a typical US stakeholders team when assistive technology is involved. But basically, as best practice globally, we have to kind of pay attention that we are avoiding assumptions about a person's ability to use wheeled mobility based on solely age. We need to make sure that as clinicians, we're completing a really detailed assessment. Involve all the stakeholders. If you're new to this, it's great if you can say that, I know clinically what I think I want. Turn to your supplier, or if you're a supplier, bring it to your clinician if they're green, and say, this really might help this person, and not really limit what you think about because of the age. In the US, a lot of people post-stroke are prescribed the K4 still, just because strokes don't need an ultralight. And then also you want to maintain that up-to-date local equipment supplier relationship. And then train. A big piece of what we're supposed to do as clinicians as well as suppliers is really work on skills training. It's not enough to give them a device, especially in the older population. They need training. I'm not going to walk us through the research, but there is a high research reflects that there's a high population that in the older population, because of lack of training, that ends up not using their device. They're not confident. So they end up staying home more. So that training is specific. These areas of training were identified by a survey of older people who had power wheelchair use over at least for 6 months. And these were where they felt vulnerable. So these are great tasks to think about when you're kind of designing your plan of care. And if you're a clinician in the room, design your plan of care to be multiple visits. This is not issuing a walker. This is a multiple visit intervention. When you're first speccing it out, and then you can discharge, bring them back for fitting, bring them back for training, make that multiple, and there's ways to bill for that are supported by billing. So include training if we really want to make a difference. This awesome lady, Stella, I'm just going to play this briefly before we wrap up. She, look at all the maneuvering she had to do. She's got severe rheumatoid arthritis and multiple joint issues. She's got multiple power seat functions that help her. And she's highly independent in many, many functions because she's got the right features and she got practice with the right person. This is in the handout. I'm not going to go into training considerations, but there are really well-written research studies that have talked about power wheelchair training and manual wheelchair training in the older population, skills to cover, as well as considerations for frequency, duration, and approach. So lastly, this is the best. So this is a brief video of Bobby, who is Chris's spouse, with a legislator. Bobby became a strong and remains a strong advocate for disability equity in Australia. And she was with this legislator on this day moving the process or the efforts forward.
On his 69th birthday, fainted, had a fall, and as a result has become a quadriplegic. And our system is failing him. The NDIS only takes care of people with with disabilities, with plans up to the age of 65. There is nothing beyond that. So if this accident had happened to Chris prior to his 65th birthday, he would be on a plan up to something like 300,000 to assist him with very real needs of meeting his everyday care and needs. Instead, he's left, the system has failed him, and he's left with my age care plans that essentially give him assistance of about 50,000.
I'm going to stop it there. But basically,
69th birthday,
basically, Bobby became an advocate for change. So our challenge to you is globally, we all have that opportunity being in this industry to participate in change. Change doesn't just happen. We can see that with the Power Seat Elevate change that is about to roll out. Power standing is going to be reviewed by CMS in the future. So if we believe that this technology is important, then we have to participate. Permobile does have a webpage, Advocate for More, which has updates regarding what's going on. But there's also there's multiple websites in the country that you can participate in a petition writing or a public comment, and encourage your clients and patients too. You can also participate in your funding agencies, whether it be through education or sitting in on quarterly funding meetings. That's open to the public. In summary, we basically, I think, covered the topic of why the disparity is a problem and what we know in the technology that we prescribe is available. There's a few resources that are in our handout. The World Health Organization website has a really nice call to action. And then RESNA, of course, is a great resource, as well as we've got the wheelchair handbook that we wrote for consumers. It's not about Permobile product. It's about how features can help clients. And it explains to the client what they may want to consider regarding wheelchair features. So first of all, let's give you the code and then let's give time for questions.